Let's move on to the next session, which is Thalassemia Major with Hepatitis C, basically multifactorial liver involvement in a hematological disease. So may I call upon the moderator, Dr. Prabha Sawant, presenter, Dr. Tapobrata De, our panelists, Dr. Winita Hardikar, Dr. Mamta Manglani, Dr. Mukesh Agarwal, please.
Dr. Tapobrata Day will present this case of thalassemia major with hepatitis C.
Good afternoon, all my respected teachers, respected sir, madam, all the delegates, and my friends. I'll be taking up a short case of thalassemia major with hepatitis C. Now, our patient was a 12-year-old girl, first by birth order, born of non-consanguineous marriage, referred from Red Cross Society for treatment of hepatitis C in a known case of thalassemia major. Now, we just have a brief history. The parents noticed at around 2 months of age that the child was pale. They got investigated, hemoglobin was 4. HB electrophoresis revealed a beta thalassemia major in the child, following which the child received regular blood transfusions every 21 days till the age of 6 years. But the point to be noted is that the child was put on oral and injectable chelating agents only after 6 years of age. At the age of 8 years, on routine screening, hepatitis C was picked up. But the parents lacked proper awareness about the disease. Another point to be noted is that in spite of receiving regular transfusions since the age of around 2 months, the third dose of hepatitis B was still pending. The child was deficient in both proteins and calories in their daily diet, and the parents belonged to a lower socioeconomic strata. On a brief clinical examination, the child had a hemolytic facies, pallor was evident, there was wasting and stunting present, and other relevant finding was a hepatosplenomegaly. You can see the darkly pigmented skin, which probably results from frequent transfusions, and this is the child with a hemolytic facies evident. Now, coming to the baseline investigations at the time of presentation, the hemoglobin levels were normal, probably it was a post-transfusion one. The HCV genotype was done. It would reveal the genotype of 1. The initial HCV RNA viral load was 1,77,000 international units. The other significant finding is that ferritin levels is significantly high, around 3,800. The other findings were hepatitis B was negative.
So before we come to the treatment, now transfusion transmitted infections have always been a major problem in multi-transfused patients. So Dr. Mukesh, how frequently in a patient who has received multiple blood transfusions will you look for viral markers like HBsAg, anti-HCV and HIV?
Hello. Actually, there are no clear-cut guidelines, and now there are strict regulations about the testing of the blood from the blood bank. So we cannot have a standard format that when that assessment should be done, but at least on the 2 points, the assessment is a must. One, when the patient is first time you are enrolling in a thalassemia unit. At that time, you don't know whether the patient has received the transfusions outside and how was the quality control. So at least at that time, at least for the medical legal purpose, we should have the screening for these transmitted infections, number 1. Number 2, there are times when we clinically suspect that the patient may have any complication. And in these clinically suspected, then we can have the need-based testing rather than having a routine testing.
So you will do a test for viral markers at baseline, and if there is an ALT elevation, probably you'll repeat the test. That's what you want to say?
Not the viral markers, madam. Simply we have to do, most of the times antibody testing is enough in these patients.
Okay.
Viral marker only if the antibody testing suggests that it is possible, then we should go for the viral marker.
What in your experience is the prevalence of HCV in children of thalassemia?
No,
You
can
can
I
take
respond also
Yeah,
to
sure.
this? See, though there is no strict guidelines, but the Thalassemia International Federation has laid down that annually at least you may do a routine antibody testing for HCV, for HIV, and for hepatitis B, the antigen. So generally most centers follow that, though I agree with you that there is no strict guidelines because it may not be of great value, because especially in the Western world where now these infections are not as common as they were earlier. The second question that you asked was about
HCV prevalence in the setting
Yeah.
of thalassemia
In the
major?
past, when we were not screening our blood regularly for HCV, we in our own center had 43% prevalence of positivity for the antibody. We never did the viral markers at that time. And as soon as in 2002, it became mandatory by the State Blood Transfusion Council in Maharashtra to start screening, after which we have analyzed our data and it has dropped to 11%. So that is the remarkable difference that it has made just by proper screening of donor blood and discarding positive blood. But world over, or rather in the developing world, the estimates of HCV positivity vary from anywhere between 10% to 60 to 70% in multi-transfused thalassemic children.
It is more than hepatitis B.
Yeah, much higher.
So what about vaccination for hepatitis B? Do you start vaccination in these children before you give your blood transfusions?
Madam, hepatitis B vaccination is a regular vaccination, routine vaccination. So as such now, it is not only the thalassemics, but non-thalassemics also should receive a regular hepatitis B vaccination. Of course, if the patient has not received at a regular time and the patient is coming, then the 3 doses of hepatitis B, all 3 doses, in this patient 1 dose was missed, but all 3 doses have to be given at a proper time, that is 0, 1 and 6 months.
Yeah, in fact, we can even give it at 0, 1, 2 if
Yeah.
required, because if they are already started transfusions, we don't want them to get the load of the virus before they have the antibody formation. So at first time when they come pre-transfusion, first dose is given, and then naturally you have to wait till 6 months if you have to go by the regular schedule. So we make it an accelerated schedule where we give 0, 1, 2, and often some centers also give at 12 months a 4th vaccine. And some people are of the opinion that a booster may be required based on the antibody levels.
Now, Mamta, you are heading a large thalassemia unit in the city. So, in your thalassemic major patients, can you tell us about blood transfusions and how much do you transfuse these children, and what's the optimum hemoglobin you would like to have in these children? And secondly, you can take this part of when do you start chelating agents?
Yeah, in fact, I was surprised that this child was started very late, chelation therapy. Normally, transfusion is begun as soon as the diagnosis is firmly established that this is a thalassemia major and not a thalassemia intermedia. Because you must differentiate these two, because the outcomes of both these are very different, the prognosis is different, the treatment is now different. We use hydroxyurea in thalassemia intermedia, which works beautifully well, and most of the children don't ever require transfusions once the hydroxyurea starts acting. But for that, you have to have a waiting period in those children who present to you late. In this case, this child presented pretty early, I believe, 6 months of age. So here there is no doubt this is a thalassemia major only. Now, in such a patient, obviously you will start immediately packed red cell transfusions after doing the baseline workup which we have discussed, and also establishing the diagnosis firmly. 15 to 20 ml of packed red cells per kilo is a dose one needs to give over 3 to 4 hours at the rate of 5 ml per kg per hour. Very often they are under transfused, and under transfusion often leads to a lot of hepatosplenomegaly, which compounds the problems of the other problems that come up with transfusion transmitted diseases, etc. So that is one point I would like to make. Chelation therapy ideally should begin when 10 to 12 transfusions have been given. So it happens around 2.5 years of age generally, 2 to 2.5 years of age. And this child was begun at 6 years. The ferritin level at which chelation should be started is 1000 and above. So anything above 1000 nanograms per ml, one should begin
Which chelating agents do you prefer?
Now there are, fortunately for doctors, we don't have to remember too many because there are very few available to us clinically. There are 3 chelators in the market. One is the injectable subcutaneously used desferrioxamine, which is given in the dose of 20 to 40 milligrams per kilo per day, subcutaneously given 8 to 10 hours a day, and generally a night, I would say 5 to 6 nights a week. The patient will take it through the pump. Now, this is a chelator which was popular because in the 70s this was the only chelator available. Slowly in 1990s, mid-90s, we got an oral chelator called the deferiprone or Kelfer or L1 as it was popularly known during the trial time. And this is a chelator which you need to give at 75 to 100 milligrams per kilo per day. This has some side effects which are a problem when you have hepatitis C, which we will allude to later probably. And then the third one is the Defra-Cyrox, which is a recent chelator available to us since last 2 years. And this one can be used in the dose of 20 to 40 milligrams per kilo per day to be given orally, single dose. The Kelfer is given in 3 to 4 divided doses, whereas this is given as a single dose. So there is an advantage. Also efficacy-wise, Desferal was very efficacious for liver iron. Deferiprone was very efficacious for cardiac iron. Over time we have learned that. Defra-Cyrox apparently seems to be efficacious for both and therefore would take care of both the aspects.
Now, Winita.
Just a minute. Madam, whether there is any use of giving the 2 chelators together?
Yes. In fact, nowadays we like to use combination chelators because if you use, as I said, that desferrioxamine is good for liver, deferiprone is good for cardiac, we can combine them 4 days of deferiprone, 2 days of desferal, and you can have a good control of both liver and cardiac iron. Now, deferiprone plus Defra-Cyrox, there is only one anecdotal report in the literature where the patient was started on both the drugs in combination on insistence by the patient and with consent of the patient. We have also begun in couple of patients this combination, but it is not a recommended combination.
Now, Winita, before we move on to the case, suppose you have, because you have a lot of postgraduates here doing pediatrics, suppose you have a HCV positive mother. And what about this perinatal transmission to the child of HCV, and how frequently will you monitor the child?
So
perinatal transmission.
So overall, the perinatal transmission rate's 5% or less. So
Yes.
it's very low.
Yeah.
We don't recommend anything special. We don't recommend caesarean section. Now there's 2 levels to answer that question. We can't recommend it based on the data, but the data is based on the fact that because there's so few cases of transmission, you need a huge study to show a benefit of caesarean section. So we really, I don't think, have enough data to say, but there's nothing that says it's protective. Breastfeeding is again allowed after delivery, provided there's no blood from the nipple, so no mastitis. In terms of testing, when does the child have hepatitis C? Again, there's 2 answers to that question. There's a cheap answer and an expensive answer. If you've got a private patient who's insisting on wanting to know and they're hounding you with phone calls every day, then sometime after the age of 3 months you can do a PCR and liver function tests. And again, you can't reassure them 100% because the PCR can be intermittently positive and the liver function test can be intermittently abnormal. If you want a definitive and a cheap answer, you test them once with HCV antibodies at the age of 18 months.
Yes.
And that will give you the answer.
Yeah, so at 18 months you look for anti-HCV, and less than 6 months, if the parents really want to know, you can get the HCV RNA. What are the different options for treating hepatitis C? In this case scenario, would you give monotherapy with pegylated interferon, or would you like to give pegylated interferon with ribavirin?
So there's no monotherapy for hepatitis C. It's not worth treating anybody with hepatitis C with monotherapy. It doesn't work. It will reduce the viral load, but you'll get an immediate recurrence. So the purpose of the ribavirin, the second agent, is to prevent recurrence. So there's absolutely no point in monotherapy. In terms of treatment, we take a few different things into account. So we take into account the genotype. So obviously genotype 1 is going to be less responsive to treatment than genotype 2 or 3. That's the first thing. There are subgenotypes which you may or may not have access to. The other thing we check is IL-28B. Are you able to do that here
Yes,
or
we are
not? You
able to
can.
do, yeah.
So genotype tells you the type of virus it is, the genotype of the virus, and some genotypes of virus are very responsive to treatment. So genotype 2 and 3 are very responsive to treatment. Genotype 1 is very poorly responsive to treatment, so that's important. IL-28B is checking the genotype of the person who has the hepatitis B. Some people are more responsive to interferon than others. So there are certain types of IL-28B genotype where you have a very favourable, very high likelihood of response, 80%, so you'd go in and treat those people, where other people have a very low response rate. So we take those two things into account, and then you take into account the clinical state of the patient and how likely they are to tolerate the therapy.
Now, in pegylated interferon, what I would like to ask you, this is a child, would you like to give weight-based pegylated interferon alpha 2b or the fixed dose pegylated interferon in the child?
Yeah, we tend to give weight-based.
Weight-based.
Yeah.
And how much of pegylated interferon? Weight-based?
Do you use alpha 2A or 2B?
No, I'm asking weight-based alpha 2b.
2B, okay. I use 2A, so I don't know the way. Does somebody else will know? It's in the literature. We use 2B.
1
unit, 1 millunit per
Per
kg.
minute.
1.5.
Weekly,
76
1 to
weeks,
1.5
5, yeah.
per weekly. We give it weekly peg
Yeah,
interferon.
regulated, yeah.
And the other one is thrice weekly, that is 3 milliunits per kg.
That's the standard,
Yeah, that's
conventional.
standard.
We don't use conventional, usually it's
I'm
pegylated.
just telling for those
Yeah.
postgraduates should know the doses in
Yeah.
both.
So, Winita, what are the factors which you consider are very important while considering effective therapy? Which patients you feel will do well? Which patients you feel you have to stop the therapy in this situation?
So the factors that predict very, very reliably are genotype and IL-28B. The background of the patient really is to do with their ability to tolerate the therapy, how sick they are, etc. And we use response-guided therapy in all patients. So we check the viral load at week 4, which is a rapid viral response, and again at week 12. And if the virus is at week 12, if your virus hasn't either disappeared or dropped by 2 logs, you should stop therapy, because the chances of continuing are very unlikely to result in clearance of the virus. So we tell the families that the length of the therapy depends on the type of virus your child has and what genotype you have, but at 3 months we will reassess, and if your child is not responding, we will stop at that point.
What about ribavirin in this situation of thalassemia? What exactly, with the hemolysis, is there more requirement for blood transfusions? So how do you take care of these children?
So there's been a few. No, I'm talking in terms of theoretical here, because we don't look after thalassemics at all. We hardly have any at all.
Yeah.
And our youngest transfusion-acquired hepatitis C would be around 25 or so because we started screening in 1989 or 90, so we don't have any paediatric patients with transfusion-acquired hepatitis C. Now I've talked so much, I forgot your question.
So I said ribavirin induced
Oh yes, sorry,
hemolysis.
yes. So we still do treat with ribavirin, and there are some good papers, some very big studies from Greece and Italy using ribavirin in thalassemic patients. It is still required. You might need to lower the dose, and you do need to support with transfusions, but that shouldn't mean that you don't use it. If you're not going to use ribavirin, don't bother treating.
So
No,
patients.
we have seen in a couple of patients where the transfusion requirement went to, I don't know, it was terrible. Every weekly we had to transfuse the children. And ribavirin also can lead to neutropenia, as we know, lymphopenia, thrombocytopenia. I mean, all these are known. So we do monitor CBC very rigorously during the treatment of hepatitis C. And without ribavirin, responses are not supposed to be good, so we don't want to give only interferons, are not going to give us a good response. So we often have to stop the treatment, restart the treatment. There have been interruptions if there is severe neutropenia. We do give GCSF to tide over the neutropenia. It helps, but it is again supportive care. Similarly, erythropoietin, some reports have said would help in tiding over part of the anemia, because it's not all possible to tide over because it's hemolytic.
Yeah, they say erythropoietin should not be used in this subset because there's ineffective erythropoiesis. So it's better to give
Yeah,
some, they say it's better to give blood transfusions.
Basically transfusions,
Yeah.
but still we have used EPO also, let me tell you, in desperate situations, though literature is controversial about erythropoietin.
And about assessing this iron concentration in the liver, there's no need of doing a liver biopsy. So what's your take on this?
Yeah,
So,
in fact, the gold standard for knowing the body iron is a liver biopsy, liver iron concentration on dry weight liver, and it should not exceed 15. If it is more than 15 milligrams, it's a bad prognosis. It should be maintained below 7 milligrams per gram dry weight liver. It is an invasive procedure. Obviously, no parent would like you to keep doing it, especially because you have to check it serially. So the next best is to do a MRI. The T2 star weighted MR has shown very good correlation with the liver iron concentration. In fact, Dudley Pennell and group have done studies where they have even shown the cardiac biopsies done and then the cardiac iron overload correlating with the T2 star weighted MR. So today's gold standard for evaluating iron overload is the T2 star weighted MR, which should be done as required but annually in most patients.
and even if a patient develops myocardiopathy, you should not start treatment for HCV. Let's see what this patient received because we have just 1 minute.
This patient actually has a IL-28 genotype of CT, that is having a 80% SVR response. We started the patient. No, this patient had CT type of IL-28B.
CC.
No, IL-28B genotyping, there were here it is reported as CC, CT and TT. So the CT is having a 45% response of SVR.
Okay. I was going to say it depends on which SNP you use, but that's okay.
So what are the lessons?
Yeah.
Can I make one point about treatment? The most important thing about treatment in hepatitis C is not what to treat, but whether to treat or not. And there's no mandated reason to treat a child who is otherwise reasonably well, given that in about 4 or 5 years we'll have oral-only therapy without ribavirin. So you could just wait as well.
Actually, in this patient, we gave pegylated interferon 2 alpha. Initially started on the recommended dose, which had to be reduced due to the side effects. The reduced dose was better tolerated. The ribavirin was initially started at lower dose in view of low hemoglobin. Gradually, we could go up, but still we couldn't go to the full dose. Lowest hemoglobin during the entire course of treatment was 9. The lowest total counts were 2,900 and platelets were 82,000. This is the lowest counts. So it could be managed. The total counts could be managed during the course of treatment. Only it required the increasing the frequency of transfusions. The frequency of transfusions were increased from every 21 days to every 15 days to tackle the problem of lowering of the hemoglobin total counts and the platelets. And also this increase in the frequency of transfusions necessitated an increasing in the doses of the chelating agents, that is both the oral deferriprone and the injectable desferrioxamine, which was used in this case. The chelating agents doses were increased. And in this child, the EVR, that is at 3 months, there was a 2-log reduction in the HCV viral load. At 12 months, that is the ETR or end treatment response, was also favorable. And finally, the sustained viral response, which is done at 6 months post-treatment, we could achieve that also in this case with pegylated interferon alpha and ribavirin at reduced doses.
You know, Prabha, I would not continue deferriprone in this child. It has to be withheld. When you have a neutropenia, you cannot afford to give deferriprone because if you have severe neutropenia with the iron chelator on, you can really end up in sepsis and death. So you are giving anyway desferrioxamine. So continue only desferrioxamine. In fact, there are papers and literature which says give IV 3 months desferrioxamine daily to reduce the iron overload drastically, because as we know, HCV is dependent on the iron for creating that free radical and causing further liver injury. So in fact, we could do even that, but not continue deferriprone. I mean, that's one reservation I would have, but otherwise, patient has done very well.
I thank the. You would like to show us the lessons we have. Do we have time to show lessons we have learned, or Okay. I thank all the panelists and the person who presented. Thank you.
Thank you.
Thank you.